It's not moving. If he can risk his cornea for a national award, we can at least sit up and listen to this class on fungal keratitis to treat him if he ever walks into our OPD. It affects the working population, our humble farmers with high morbidity. While antibiotics keep on evolving and we have a new one coming up every 5 years, natamycin has been our first line treatment since 1960s. While signs like pseudodendrites, satellite lesions, endothelial plaques with raised lesions, a thick hypopyon, immune ring, pigmentation are all signs which could hint towards a fungal keratitis, feathery margin is the one sign that would lead us to the diagnosis. As per mud trial, it is the most specific sign for fungal keratitis. Even the best of us can get puzzled when similar looking lesions plant themselves on our slit lamp. One of our tools is the confocal microscope, which can help pick a fungal element. So when we are stuck in dilemmas like Tani partner, always trust our good old corneal scraping. Scrape the leading edge and center on a slit lamp or under a microscope with care to not perforate. Maybe learn to check the slides on a KOH mount yourself with that cute microbiology resident and treat him later. These staining methods will confirm what we suspect. These thick bamboo-like elements is what fungal hyphae would look like on KOH mount. There's always a chance of finding coexisting bacterial and fungal elements on the KOH mount. These round or oval budding forms indicate yeast. However, when we have limited scraping, always choose to perform gram stain as it is far more sensitive for both bacterial and fungal elements. Some fancy stains like GMS and calcifluor can always help in case of a dilemma, while cultures help guide treatment. PCR should be reserved exclusively when there is a very small sample. Needs to be interpreted with care as it is very sensitive and artifacts can get amplified. The medical management consists of topical, intrastromal, and oral antifungals. Polyenes like amphotericin, natamycin disrupt the cell membrane, while all azoles cause inhibition of production of cell membrane. The giant cosmic mud trial established the basis of using natamycin as the drug of choice for all fungal keratitis. And why not? Look at those ragged edges become subtler and more well-defined. But even Sachin Tendulkar can get stumped at 2 runs. So can our natamycin by bowlers like diabetes, dacryocystitis, or contamination. Our next weapon is the intrastromal injection with voriconazole or amphotericin. However, we have no RCTs to prove their efficacy. Rather, intracameral is preferred. The only indication for adding oral antifungals is scleritis and endophthalmitis with careful LFT monitoring. However, MUD2 established no added benefit by adding oral voriconazole to topical agents. All these conclusions are today incorporated by topical systemic targeted therapy protocol. First line of defense continues to be natamycin with or without addition of oral antifungals in severe ulcers, addition of voriconazole as a second line of defense, and intrastromal and intracameral antifungals as third line of defense. And when all fails, TPK saves. So when do we pick the scalpel? When we are suspecting a perforation for a stubborn non-healing ulcer after ensuring adequate and appropriate treatment when there's threat to limbus or additional sequelae like secondary glaucoma. Our goal is very clear. Eliminate the infection, protect the integrity and prevent sequelae. Start with measuring, refining the host cornea, separate the membrane from a lens if any, make a huge PI, aim for perfect, equally spaced radial sutures, neither too tight nor too loose, ensuring a well-formed AC. With your good karma, maybe you'll be lucky enough to end up with a clear graft after your TPK. But I'm here to tell my other students with their not so good karma that even if you end up with a failed graft, it's not on you. It's an expected outcome in TPK. Just as much as a clear graft is, which can get infected and again become a failed graft. In the end, I hope you go back home remembering that despite a million clues, microbiological confirmation is mandatory. Start with natamycin, escalate as appropriate, and have realistic goals of infection eradication from your TPK. Thank you.
Very nice.
Last but not the least.
Thank you so much. It's not the last, so we still have 2 more presentations. One team came late.
Is there any role of glue? Glue.
Glue. In case of TPK, you mean for TPK?
For fungal corneal keratitis.
That's a good question.
Thank you.
And I'm very proud of my students who've read up so well and stumped my teacher and stumped the teachers. North is more known to be as affected by fusarium, while the south is affected by aspergillum. But the drug of choice continues to be natamycin for all fungal keratitis.
What percentage of ulcers are expected to be fungal?
60, the load of fungal to bacterial is 60% in our country as opposed to the rest of the world where bacterial is a bigger issue.
So
No,
last team
the
is
load of fungal is much
GG's
more than
Glare
bacterial in
Busters.
our
Huh?
country.
Yeah, start.
It's the 60%, that's what the mud, the mud trials, mud trial.